Hello everyone. First and foremost, I thank Dr. Soumya and Shankara Academy of Vision for giving an opportunity to share my experience on buckling surgery. I'm Dr. Rajesh, consultant Vitreo-retina and Ocular Oncology, Sankara Eye Hospitals, Bangalore. Retinal detachment is a separation of the inner layers of the retina from the underlying retinal pigment epithelium. There are various forms of retinal detachment, which includes tractional retinal detachment, exudative retinal detachment, and rhegmatogenous retinal detachment. In this presentation, I'll be talking about rhegmatogenous retinal detachment factors which contribute for the normal adhesions. There are two factors: one outside the subretinal space, which includes the intraocular pressure, the oncotic pressure, and the vitreous support, and inside the subretinal space, which includes mechanical interdigitation with the RPE cells, interphotoreceptor matrix complex, which adhere to each other. So, coming to the causes or the predisposing factors for retinal detachment, these include the most common being the posterior vitreous detachment, which includes lattice, cystic retinal tuft, myopia because of the thinning of the retina, retinoschisis, trauma is more so in the young, iatrogenic such as cataract surgery, any other intraocular surgeries, and procedures such as capsulotomy. Familial predispositions such as Stickler syndromes, golden fiber syndrome might also contribute. Coloboma, we all know, which might lead on to breaks and the subsequent retinal detachment associated with it. The principles of retinal reattachment surgeries include relieving traction or creating a temporary chorioretinal adhesions, which might be a buccal, or internally, which includes intraocular gases, air, subretinal fluid drainage, which was widely advocated by Skippons, and a permanent method for the closure of the break, which includes diathermy to start up with, and then we moved upon to cryoretinopexy and photocoagulation. The indications of buccal surgery are straightforward, but let us look into the therapeutic aspect, which includes fresh rhegmatogenous retinal detachment with a single break, multiple breaks all in a single plane. PVR, that is proliferative vitreoretinopathy, should not be more than C2. The retinal dialysis, which is one of the ideal cases to do a buccal surgery. Prophylactically, patients who had acute retinal necrosis before the break formation, or a fellow eye of a giant retinal tear, white without pressure. So let us go into the procedure per se. To start up with, we do 360-degree peritomy and tenotomy. We start up with a small radial cut, commonly or conventionally, we can say from the superior temporal quadrant, and go along this plane, create a plane, and go along the same 360-degree all around the limbus. Nowadays, we usually carry on this dissection flush to the limbus. Once 360-degree of peritomy is done, relax peritomy is done in the infranasal and supratemporal quadrant. Post to this, each quadrant tenotomy is done by using a blunt scissors and dissecting it. Once the peritomy and tenotomy is completed, the next procedure is hooking of muscles, which is carefully done to make sure that we hook the entire muscle, and then bradling it with usually silk sutures. Once the muscle are hooked and bradled, the next most common would be to localize the retinal breaks. So retinal breaks identification and marking is done. The marking is done either using a cautery or a Indian ink pen. Once this is done, the next would be to do a cryoprexy, which includes to create a permanent chorioretinal adhesion. Cryotherapy involves either directly onto the break when the break is equal or less than 1 disc diameter, or if it's more than that, then a 3 point is marked on the lateral sides and the posterior aspect, and a cryo is done all around the break. DAYS protocol is used when there is a bullous retinal detachment. Indications of subretinal drainage includes bullous retinal detachment, compromised retinal pigment epithelium, glaucoma, chronic and infraretinal detachment because the subretinal fluid is very thick and its resorption might take a very long time, or doing a subretinal fluid drainage, or the site of doing a subretinal fluid drainage includes a site where there is a maximum retinal separations to prevent any sort of incarceration into. So we should also avoid areas where cryo has been done, major choroidal vessels, and directly below a break. So the methods, there are two basic methods which are done. One is direct visualization, which is shown in this video, which was advocated by Rosen, and a blind procedure where a needle is just inserted in through the transscleral approach, respecting the horizontal or the vertical meridian, which was advocated by Charles. This is the Charles method, where a 26 gauge needle is just blindly inserted into transclerally into the subretinal space, and the posterior lip is pressed upon to make sure that adequate drainage is achieved. When you expect the subretinal fluid to be very thick and wouldn't drain as easily as the needle technique, or if the subretinal fluid is shallow, then the cut down technique is better, where the sclera is cut down, then exposing the choroid. Once the choroid is exposed, cauterize is done, and then the 26 gauge needle is inserted through this area to drain the subretinal fluid. After the subretinal fluid drainage, we usually place the buccal or the exoplant. These are numbered. So the odd numbers are the one which are symmetrical, like 287, and the even numbers which are asymmetrical. Encerclage, there are two types: the 240 band, which is about 2.5 mm, or the 42, which is about 5 mm. The principle on which the buccal works is called as the Hooke's law. Procedure is explained here. Two radial cuts are done for creating a scleral tunnel. This can be supplemented by using sutures also. Usually we use 50 ethibond to create tunnels through which the encircling band is placed. After the tunnels are created, the 240 band is passed, usually starting in the superior temporal quadrant. So after passing through the tunnels, it is passed below the insertion of the recti muscles. We should always make sure that the um, encircling band is not tangled and is in the same plane all through. Once it is both the ends meet at superior temporal quadrant, a tie is placed. The tie is either through a sleeve, which is shown in this video, or an ethibond, 50 ethibond can be used with a claw hitch knot. Post this, the segmental buckle, which has been predetermined, is placed. Any of the surgical procedure is not devoid of complications. So is for buccal surgery also. In intraoperative complications, there might be corneal clouding because of the hydration, meiosis of the pupil, scleral perforation when we are doing the subretinal fluid drainage. Complications associated with drainage include a dry tap, where the subretinal fluid is thick, or we might have entered into the wrong place, a retinal break, a retinal incarceration, subretinal and choroidal hemorrhage, which is devastating, sometimes devastating in nature. Post-operative, there might be a rise in the pressure, which can cause glaucoma. If there's extensive handling of the muscles, it might cause antersegment ischemia, ciliachoroidal detachment, persistent retinal detachment, proliferative vitreoretinal because of the cryo, infection of the buccal and extrusion. Outcome of the buccal surgery, the anatomical success usually depends on the surgeon skill, macula involved or not involved. The advantages of buccal surgery is very obvious. It's a very external procedure. The chance of infection, the cataract progression are very, very minimal or nil. Thank you.